Welcome back to MRCP PACES with Dr. Owais. In my last video, we covered the format of the PACES exam, the stations, the timings, what to expect on the day. If you haven't watched that yet, I'd recommend going back and starting there. But today, we're getting into the heart of this exam, the single most important thing you need to understand about PACES, the 7 core skills. Skills A through G. And here's what most candidates don't fully appreciate until it's too late. You don't just need to pass the exam overall. You need to pass every single one of these 7 skills individually. A brilliant cardiovascular examination cannot save you if you fail clinical communication. The examiners do not average out your marks. They look at each skill on its own. In this video, I'm going to break down all 7, what they are, what examiners are actually looking for, and how you score maximum marks in each one. Let's start with the big picture. This is what the examiners are holding in their hands during your exam, the PACES mark sheet. Across the 5 stations and 8 patient encounters, you're assessed on 7 skills, labeled A through G. Each skill is marked on a 4-point scale. A clear pass gives you 3 points. A borderline pass gives you 2 points. A borderline fail is 1 point, and a clear fail is 0. There are 56 individual assessments across the whole exam. That gives a total possible score of 168 marks. The overall pass mark is 126 out of 168, exactly 75%. But here's the part I really want you to pay attention to. You must achieve at least a borderline pass in every single skill. Let me say that again. You cannot compensate for failing one skill by doing brilliantly in another. The examiners have a full profile of your performance. If any skill falls below the pass threshold, even one, you fail the entire exam. This changes how you need to prepare. You can't afford weak spots. You need to be competent across all 7. Now let's go through each skill one by one. Skill A, physical examination skills. This is the foundation. Everything starts here, and examiners are watching your technique from the moment you walk up to the patient. The first thing they're asking is, does this candidate know how to perform a systematic, competent physical examination? So what scores you marks? First, your approach. Do you introduce yourself? Check the patient's name? Explain what you're going to do and gain consent? Position the patient correctly? These aren't just formalities, they are part of the skill, and they set the tone for everything that follows. Second, your technique. When you palpate the abdomen, are you using the flat of your hand? When you percuss, are your strikes sharp and consistent? Is your stethoscope actually on the patient's skin or hovering over their gown? These tiny details matter more than you think. Third, your system. Examiners love a logical, structured approach. Inspection, palpation, percussion, auscultation. In that order, every time. If you jump around randomly, you look disorganized and you will miss things. Fourth, no significant omissions. For cardiovascular, you must check the pulse, blood pressure, JVP, apex beat, and auscultate in all 4 areas. Miss the JVP? That's a significant omission, and that costs marks. And fifth, patient comfort. Are you exposing only what you need? Keeping the patient covered between steps? Being gentle. This feeds into skill G as well, but examiners are noticing it here too. The bottom line for skill A, be systematic, be thorough, be gentle, and don't miss the key steps. Skill B, identifying physical signs. Now this is where many candidates lose marks, not because they can't find the signs, but because they can't communicate what they found clearly to the examiners. Skill B is assessed when you present your findings. You've examined the patient, and now you have about 2 to 3 minutes to tell the examiners what you discovered. Here's what they're listening for. First, clarity of description. Don't just say, "I heard a murmur." That tells the examiner almost nothing. Say, "I heard a pansystolic murmur, loudest at the apex, radiating to the axilla, grade 3 out of 6 in intensity." Be specific. Use the correct terminology. Second, normal findings. If everything is normal, say so confidently. Many candidates start waffling when things are normal, which makes the examiner wonder whether they actually examined the patient properly. Practice saying normal findings out loud until it sounds as natural as describing abnormal ones. Third, interpretation. After describing the sign, tell them what it means. The displaced apex beat suggests left ventricular enlargement. The early diastolic murmur suggests aortic regurgitation. Show them you understand the significance. Fourth, honesty. Sometimes you genuinely won't be sure. That's okay. What's not okay is pretending. Say, I'm not entirely certain, but I believe there may be a soft early diastolic murmur. I would like to listen again with the patient sitting forward in expiration. That shows clinical judgment. And fifth, link your signs together. If you found multiple findings, connect them. The displaced apex beat, the pansystolic murmur at the apex, and the basal crackles all point toward mitral regurgitation with secondary pulmonary edema. Finding the sign is half the battle. Describing it clearly and interpreting it accurately, that's what gets you the marks. Skill C, clinical communication skills. This is assessed in 4 out of 5 stations. It is everywhere, not just in the dedicated communication stations. And communication in PACES isn't just about being friendly. It's about specific, observable behaviors that examiners are trained to spot. So what are they looking for? First, structure. Do you have a clear framework? Good candidates introduce themselves, establish rapport, use open questions to hear the patient's story, clarify and summarize, explore their ideas, concerns, and expectations, explain their findings in plain language, check understanding, and agree on next steps. Second, a patient-centered approach. This is huge. Do you ask, what do you think might be going on? What are you most worried about? What were you hoping I could help with today? These questions show you care about the patient's perspective, not just the diagnosis. Third, avoiding jargon. If you say dyspnea or hematemesis to a patient, you lose marks. Use plain language, shortness of breath, vomiting blood. If you must use a medical term, explain it immediately. Fourth, active listening. Do you pick up on cues? If a patient mentions their mother died of cancer, do you acknowledge it? Say, that must be concerning for you. Tell me more about that. Ignoring cues is one of the most common mistakes I see. Fifth, nonverbal communication. Are you sitting down, at the patient's level, making eye contact, looking at them rather than your notes? Sixth, shared decision-making. At the end, don't just tell the patient what will happen. Say, based on what you've told me, I think we should consider these options. What are your thoughts? That shows respect for patient autonomy. And seventh, safety netting. Always end with, if things get worse, or if you have any concerns, here's what you should do. The test I always give candidates for Skill C is this: would I want this doctor looking after my own family member? If the answer is yes, you're passing. Skill D, differential diagnosis. This is tested in the consultation stations and during the examiner Q&A after examination stations. Examiners want to know, can you take the information you've gathered and generate a sensible, prioritized list of possible diagnoses? The key word there is prioritized. A list is not a differential. A ranked, justified differential, that's what scores marks. Here's the framework. First, give your most likely diagnosis first. After a chest pain history, don't start with 10 possibilities. Say, based on this history of central chest tightness radiating to the jaw, brought on by exertion and relieved by rest, the most likely diagnosis is stable angina. Second, then provide your differential. Add, however, I would also consider gastroesophageal reflux given the postprandial nature of some episodes, and I would want to exclude unstable angina or NSTEMI with an ECG and troponin. Third, structure it by probability. Most likely first, then less likely, then serious conditions you don't want to miss, even if they're unlikely. For breathlessness, most likely COPD exacerbation, less likely pneumonia, and I must exclude pulmonary embolism. Fourth, link to your findings. Your differential should be grounded in what you actually found, not just textbook possibilities. Fifth, be prepared to justify. Examiners will ask, why that one first? What makes you think it's not X? Have your reasoning ready. And sixth, know when to say you need more information. That's not weakness, that's clinical honesty. The most common mistake? Giving an unranked list. It could be angina, or reflux, or musculoskeletal, or anxiety. That sounds like you have no idea. Always lead with your most likely diagnosis and defend it. Skill E, clinical judgment. This assesses your ability to formulate a management plan, and the key word here is structured. Examiners don't want a vague response. They want to see you think the whole patient journey, from the moment they arrive to the moment they go home and beyond. Here's the structure that gets top marks. First, give immediate investigations. What tests do you need right now? Be specific. I would perform an ECG immediately to look for ischemic changes. I would check a chest X-ray. I would send bloods, including FBC, U's and E's, LFTs, and troponin. Don't just say bloods, name them. Then, further investigations. What helps confirm the diagnosis or assess severity? An echocardiogram for the aortic stenosis, pulmonary function tests for suspected COPD, a CT scan if there's no improvement. Then immediate management. What are you doing right now? Oxygen, nebulizers, IV fluids, antibiotics? Be specific, be clinical. Then short-term management. What happens in the next 24 to 48 hours? Review blood results, adjust treatment, involve the relevant specialty. Then long-term management. What about after discharge? Smoking cessation, medication optimization, lifestyle changes, rehabilitation. And finally, safety netting. What if things go wrong? I would advise the patient to return immediately if symptoms worsen. If they deteriorate, I would consider ITU referral. And always consider patient preferences. Have you asked what they want? The patient has expressed a preference for conservative management, so I would respect that while ensuring they fully understand the risks. Think the whole journey. That's Skill E. Skill F, managing patients' concerns. This skill is closely related to communication, but it's distinct. It's specifically about how well you identify and address what the patient is actually worried about. Examiners are watching for this throughout every consultation. First, elicit concerns explicitly. Don't assume you know what the patient is worried about. Ask, what concerns you most about these symptoms? Is there anything specific you're worried it might be? What were you hoping I could help you with today? Second, pick up on cues. Patients often drop hints. My mother had something similar. I've been feeling really stressed lately. These are invitations to go deeper. Acknowledge them. Say, tell me more about that. Third, respond with empathy. When a patient shares a concern, your response matters enormously. That sounds really difficult. I can understand why you'd be worried about that. Many patients feel exactly the same way. This is validation, and it builds trust. Fourth, address concerns explicitly in your plan. When you explain your management, link it back to what they told you. You mentioned you were worried about cancer. The tests I'm arranging will help rule that out. Show them you listened. Fifth, check understanding. After explaining, ask, does that make sense? Do you have any other questions? How do you feel about what we've discussed? And sixth, manage unrealistic expectations. Sometimes patients want things that aren't clinically indicated. Handle this with respect. I understand you're hoping for antibiotics, but given this is most likely viral, antibiotics won't help here. Let's talk about what will. Patients don't just want a diagnosis, they want to feel heard. Show them you care about what matters to them, and you'll pass Skill F. Skill G, maintaining patient welfare. This runs through the entire exam, from the first second you walk into the station to the last second you leave. It's about professionalism, dignity, and patient safety. And here's something critical. Skill G can override everything else. If you compromise patient welfare, it doesn't matter how good your examination was, you can fail. What are examiners watching for? Consent. Before you touch a patient, ask, would it be okay if I examine your chest? I just need to listen to your heart, is that all right? Non-negotiable. Hand hygiene. Gel in, gel out, every single time. Examiners notice if you skip this. Dignity and modesty. Expose only the area you need. Keep the patient covered between steps. Pull the curtain. Turn away when they reposition. These small acts of respect matter enormously. Patient comfort. Is the patient lying flat when they're breathless? Are they cold? Are they in pain? Good candidates constantly check, are you comfortable? Would you like to sit up for a moment? Gentle technique. Warm your hands first. Palpate firmly but gently. Support limbs during urology exams. Rough handling loses marks immediately. Thank the patient. At the end, always say, "Thank you very much for your time. You've been very helpful." Simple, but you'd be surprised how many candidates forget. And leave the area tidy. Make sure the patient is comfortable before you go. My advice for Skill G: treat every single patient like they're your own family member. If you genuinely do that, you'll pass this skill every time. Now let's look at how these skills map onto the actual stations, because this helps you focus your revision. Station 1 covers communication and respiratory. You're assessed on skills A, B, C, F, and G. Examination, identifying signs, communication, managing concerns, and patient welfare. Notice no examination skills, because examination is part of the consultation itself here. Station 2 is the clinical consultation. Here you're assessed on skills C, D, E, F, and G. Communication, differential diagnosis, clinical judgment, managing concerns, and patient welfare. Notice no examination skills, because examination is part of the consultation itself here. Station 3 covers cardiovascular and urology, skills A, B, and G only. Examination, identifying signs, and patient welfare. Communication isn't formally marked here, but your manner with the patient still feeds into welfare. Station 4, communication and abdominal, is the same as Station 1, skills A, B, C, F, and G. And Station 5, the second clinical consultation, mirrors Station 2, skills C, D, E, F, and G. Now look at the pattern. Skills F and G, managing concerns and patient welfare, appear in every single station. Every one. They are constantly being assessed, from the moment you walk in to the moment you walk out. And skill C, communication, is marked in 4 out of 5 stations. Communication is not just the communication stations, it is everywhere. Prepare accordingly. Let's talk about why candidates actually fail, because understanding this tells you exactly where to focus. The most common failing skill is skill B, identifying physical signs. Around 23% of failures come down to this. Candidates find the signs but can't present them clearly, or they miss signs entirely. Next is skill C, clinical communication, at around 18%. Jargon, not picking up cues, not involving the patient. Then skill F, managing patients' concerns, at around 15%. Candidates simply don't ask about concerns, or they don't address them adequately. Skill A, physical examination, accounts for around 12% of failures, poor technique or significant omissions. Skill D, differential diagnosis, is around 11%, usually because candidates can't prioritize or justify their thinking. Skill E, clinical judgment, about 10%, vague management plans or inappropriate investigations. And skill G, patient welfare, accounts for only around 5% of failures in isolation, but when it combines with other skill failures, it's often the deciding factor. Here's the insight I want you to take away from this slide. Most candidates don't fail because they lack knowledge. They fail because they can't demonstrate that knowledge effectively. They find the murmur but can't describe it. They know the diagnosis but can't explain it to the patient. They have a management plan but present it chaotically. That is why understanding the MARC scheme matters. It tells you exactly what behaviors to demonstrate, and behaviors can be practiced. So how do you actually prepare for the 7 skills? Here's my practical advice. For skill A, film yourself examining patients. Use a timer. Watch it back. Ask a colleague to observe you. Create a checklist for each system and use it every single time until the structure is completely automatic. For skill B, after every examination, present your findings out loud. Record yourself. Listen back. Are you clear, specific, structured? Are you presenting normal findings as confidently as abnormal ones? For skill C, practice with colleagues role-playing as patients. Record your consultations. Count how many times you use jargon. Count how many open questions you ask. Practice the ICE framework until it happens naturally, without thinking. For skill D, for every case you see, write down most likely, less likely, serious but unlikely. Then justify each one. Do this 5 times a day and you'll build a mental library of differentials that becomes instinctive. For skill E, for every case, write a management plan following the same structure every time. Immediate investigations, further tests, immediate management, short-term plan, long-term plan, safety netting. Same framework every time. For skill F, in every patient interaction, consciously ask yourself, have I explored their concerns? Have I responded with empathy? Make it a habit. And for skill G, create a mental checklist: consent, hand hygiene, dignity, comfort, and always thank the patient. Use it before and after every patient contact until it's completely automatic. The golden rule for PACES preparation: don't just practice the medicine, practice the performance of medicine. PACES is a practical exam. You need to demonstrate these skills, not just know them. Let's bring it all together. Skill A, physical examination. Be systematic, thorough, and gentle. No significant omissions. Skill B, identifying signs. Describe clearly, interpret accurately, present with confidence. Skill C, clinical communication. Patient-centered, no jargon, use the ICE framework, involve the patient in decisions. Skill D, differential diagnosis, most likely first, then less likely, then serious but unlikely. Always justify your thinking. Skill E, clinical judgment, structured management plan, immediate, short-term, long-term, safety netting. Skill F, managing concerns, ask about them, acknowledge them, respond with empathy, address them explicitly. Skill G, patient welfare, consent, hand hygiene, dignity, comfort, and always thank the patient. And the most important thing to remember, you must pass every single skill. There is no compensation. A fail in any skill means a fail in the whole exam. But here's what I want to leave you with. These skills are not mysterious. They are not talent. They are learnable behaviors, habits you can build, frameworks you can master, techniques you can practice. Thousands of candidates pass PACES every year. With the right preparation and the right mindset, you can too. In the next video, we're going to start going station by station, beginning with Station 3, cardiovascular and urology. I'll show you exactly how to structure your examination, what the common cases are, and how to present your findings to maximize your marks. If you found this video helpful, please hit like and subscribe. It genuinely helps the channel reach more MRCP candidates who need this. I'll see you in the next one.